My name is Ijomo Obanga, and I am the Donor Relations Associate at the Royal Alexandra Hospital Foundation, and I have the privilege of being here this evening alongside incredible Lois Hole Hospital for Women Society, united in our mission to raise funds for the Lois Hole Hospital for Women. Welcome to our Between Us series. We have an engaging evening planned with a discussion from Dr. Don Kingston and Dr. Lori Pollard on the topic of maternal mental health. And now I'm pleased to welcome Becky McIntyre to share a special message with us.
Awesome. Thank you so much, Ijoma. Like you said, I'm Becky McIntyre. My pronouns are she, her, and I am excited to represent the Lois Hole Hospital Women's Society on behalf of our co-chairs tonight. Since our founding in 2017, we have raised over $1 million to support the Lois Hole Hospital for Women, thanks to supporters like many of you here today. We're thrilled to have you here as we work to raise awareness and funds for Alberta's only dedicated women's hospital, a hospital that is providing specialized care for women in all ages and stages of life. Our Between Us series was created to provide a safe space for discussing intimate and often overlooked subjects in women's health. Thank you for participating respectfully tonight, and we're so happy to have you here. It's so fun to see the numbers of participants that we know are part of these great webinars. And of course, a huge heartfelt thank you to Alberta Blue Cross for their generous support as our presenting sponsor. Your commitment allows us to host this informative series and make meaningful impact in our community. But just before we dive into tonight's session, let me share a few little housekeeping tips with everybody. Please type your questions for the speakers in the Q&A box. They will be addressed anonymously during the QA portion at the end of the presentations. And please also know that our speakers are not able to provide personal medical advice. So anything that you put in the chat box or the Q&A, just keep that in mind. And we're using a Zoom webinar. So only our panelists will be visible. You don't have to worry about your camera coming on and being part of the presentation. And this webinar can also do live transcript, which you can enable on your own device. So if that would aid in your experience here tonight, you can go ahead and find that live transcript button. And also each lecture is recorded and available on the Women's Society YouTube channel afterwards. So you can listen again if there's something you want to come back to, or you can share it with a friend. After the event tonight, please remember to fill out the feedback survey that will be emailed to you for a chance to win a $25 gift card, courtesy of Alberta Blue Cross. And now I'm happy to pass the mic over to our presenting sponsor, Alberta Blue Cross, and their wonderful representative, Marianne Hart.
Thank you very much. So my name is Marianne Hart, and I am from Alberta Blue Cross. My pronouns are she, her, and it's a pleasure to be here tonight. At Alberta Blue Cross, we value the importance of talking about women's health. As always, we are very proud to be sponsoring this series, and we're very much looking forward to hearing from Dr. Don Kingston and Dr. Lori Pollard in tonight's talk. Before we begin our lecture, we would like to share our gratitude and appreciation for the land through a land acknowledgement. Alberta Blue Cross respectfully acknowledges that we are on the traditional lands referred to as Treaty 6 territory, and that the City of Edmonton and all the people here are beneficiaries of these peace and friendship treaties. Treaty 6 encompasses the traditional territories of numerous Indigenous peoples such as the Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. We acknowledge all the many First Nations, Métis, and Inuit people who have called this area home since time immemorial. Thank you.
It is now my honor to introduce this evening's speakers. Dr. Don Kingston is a professor at the University of Calgary and holds the Lois Hole Hospital for Women Cross-Provincial Chair in Women's Mental Health. A national leader in mental health, Dr. Kingston is the co-lead on Canada's first ever guideline for perinatal mental health care. Developed in collaboration with the Society of Obstetricians and Gynecologists of Canada, the Canadian Psychiatric Association, and the Royal Australian and New Zealand College of Obstetricians, this groundbreaking initiative will establish Canada's first national standards for screening and caring for the mental health of pregnant and postpartum women. Dr. Kingston's pioneering research focuses on using e-screening and e-therapy to provide women with timely, accessible mental health care whenever and wherever they need it. Dr. Lori Pollard has contributed to the nursing profession for the last 40 years with a focus on grief, maternal child nursing, and mindfulness. Dr. Pollard is a certified grief educator, a Smart Nursing Level 1 facilitator, and holds certifications in mental health first aid, mindfulness-based stress reduction for healthcare and other professionals, and knowledge mobilization. She continues to occupy various leadership roles within Mu Sigma, the Sigma Theta Tau International Honor Society of Nurses, and has contributed to research, publications, and international presentations. Currently, she is an assistant teaching professor at the University of Alberta. Welcome both Dr. Dawn Kingston and Dr. Pollard.
Thank you. It's lovely to be here. Ijima, thank you very much.
Thank you very much. I really appreciate the invitation and to be here tonight. Thank you.
Okay. How are we doing? Can you see?
Fantastic.
All right. I think we're ready to go here. I am so grateful to be here. I think I'm on a show here. Sorry. Oh, sorry, guys. Let's get going here without a show. All right. I do want to give greetings. Actually, let me just go back for a second again. Sorry, folks. Always takes a second, doesn't it, to kind of get organized. All right. I'll start by just acknowledging that we have a sheep farm just northwest of Edmonton. And so I use a lot of sheep analogies and sheep things in our presentation. And it is lambing season. And so who can possibly not be in love with baby lambs this time of year? But I also do want to acknowledge and bring greetings from the Hope team. I love your expression that you're there. The Women's Society is there to influence, inspire, and impact. And I would say that that really resonates with the Hope team. And so greetings from Nikki Roy on the far left, Marie-Lane Smith, and Grace Chung. Tonight, we're going to talk about the current state of perinatal mental health, why we're seeing what we're seeing, reframing women's mental health and perinatal mental health within that, and how can we think about expanding our first line approaches, including screening and what we're doing there. So let's move into the current state of perinatal mental health. When we think about defining perinatal mental health, it really is the period of time between conception and when the baby is 1 year old. So that's the kind of period of time we're talking about. The prevalence or the number of women that are affected by depression or anxiety or another common mental health problem during this period is 1 in 4. And that's compared to the number of women that across their lifetime might experience some form of mental health challenge, which is 1 in 3. So in the perinatal period, it's about 1 in 4. We are seeing some indication that prenatal depression is more common than 25 years ago, and I think that's a big red flag for how we propose to go forward in terms of our system, what our system can offer. In terms of the consequences of not addressing perinatal mental health adequately, what I do want to identify is that most of the time we think, well, it's the highest dual risk, that is the highest risk to mom and baby, is when we have persistent moderate to severe symptoms. And we do see a dose response effect. In other words, the higher the symptom or the more severe the symptom, the greater the impact on the baby. But I do want to say that recent research is really identifying our work and work of others that women who struggle with subclinical and low levels of distress also have certain risk factors for their baby. And so a couple of studies, for example, at 3 years old, we found that children of mothers who had both persistent high anxiety or subclinical anxiety still had children that experienced delay. And I say that not to frighten us. I say that to say we need to not just pay attention to mothers with the most severe symptoms, but also to mothers who have low levels of symptoms. And subclinical are those symptoms that if a mother were to do a screening tool, let's say the cutoff was 10, so that everybody that scored 10 or above on that tool was identified as having depression, mothers that have 7, 8, 9 are also, candidates for help and for support. Let's think a little bit about screening and assessment. What is the case for screening? What we found in our work is that women don't feel comfortable raising issues of mental health with their providers, and providers don't ask. Why don't they ask? Lots of reasons that we'll talk about, but they're legitimate. Lots of providers don't want to open up that Pandora's box because they don't have connections with mental health services or fear that they won't be able to get a woman into care. One of the biggest barriers to getting mental health care for women is not knowing what is normal and not normal during the perinatal period. Women tend to think, oh, this is just normal. And yeah, universal guidelines recommend routine screening, depression and anxiety in pregnancy and postpartum. What kind of tools can be used? Free tools. There's lots of research around what kind of tools are best to ask the questions and identify who might be struggling with depression or anxiety. But these are free. The patient health questionnaire and the generalized anxiety disorder are free on the web. Women can get them, and they are 10 questions. They're very simple. This particular one on the screen is the patient health questionnaire that can help assess for depression. And then the generalized anxiety questionnaire is just 7 questions that can help us to understand where the levels are at. As a provider, I'm interested not just in the total score at the end, but I'm also interested in what women validate and affirm. And then I can go to them and say, I see on this one, for example, that you've identified that you're having trouble relaxing over half the days. You see, so the individual questions can become really important for assessing as well. Also, the book we just wrote, Your Brain on Pregnancy, also has screening tools in it. So women can have some background on screening and then can put their results in context as well. So it's another resource. Well, what are some of the barriers to screening and mental health care that women experience? The number one that we identified in our work was almost 76% of women. So 3 out of 4 women told us that their partner, friends, or family have told them that their emotional swings are normal and not to worry. Now, that can be good, but it can also be not good, right? If it's sort of encouraging a woman to dismiss her symptoms. Almost 71% of women said, I think I could handle my mood on my own, and therefore they didn't want to talk to a provider, a psychologist, family doctor. 67% said I would rather discuss my feelings with my partner, friends, or family. Now, although we've identified those as barriers, are they really barriers, or do they signal to us that actually women want to and prefer to self-manage their emotional well-being? At least start there, and if they need help, reach out. 46% of women said, I don't know what would happen next if I did admit I was having emotional problems. 45%, I would worry about being put on antidepressants. 45%, I would not want to be seen as depressed or anxious. That's stigma, right? That we're seen differently because of what we're experiencing. I see all those 3 sort of barriers as system barriers. We can fix these, right? We can tell women what will happen next. We can share with women that there are many alternatives for help, and we can not focus on, you are depressed versus you are having depressive symptoms. This is something that I pulled off of an Alberta Health Services website. And again, what do you see? The advice is, if you're overwhelmed, talk to your healthcare provider, midwife, or counselor. But we've just identified that actually that's a barrier. So that's not the best advice, truthfully. And 99.8% of women in our research, Albertan women, said if my provider asked me about my mood, I could be honest. So we need, as providers, to be asking the questions, and as friends and partners as well of women, pregnant postpartum women. Why are we seeing what we're seing? Our team calls these the big four. In every piece of research done internationally across cultures, many, many countries, these are always the four things that arise as the biggest contributors to depression and anxiety in the perinatal period. Having a previous mental health challenge, stress in the past year, lack of meaningful social support, and having partner conflict. But again, I want to identify what we're actually teaching. What we're actually teaching, which is when you're pregnant, hormone changes can affect your emotions and how they feel. But you'll notice that hormones were not one of these top four. Hormones do contribute, but it's a small factor compared to the life experiences that women have. So let's think about reframing women's mental health, because we have really siloed women's mental health by hormone stage, haven't we? We see adolescence, pregnancy, postpartum, menopause, and seniorhood mental health for women as separate silos. And I think that this has masked what might actually be going on. We see if a woman has struggled in pregnancy with depression or anxiety, and that it reoccurs in menopause or seniorhood, we say, she's had a recurrence or a relapse. But I want to propose something slightly different based on this evidence. 25% of women in pregnancy have experienced depression or anxiety, same in postpartum. The data at 1 year, 30%, 2 years, 30%, 4 years, 15%, 21 years, 20%, 21% of women, 21% at 21 years of women who experienced depression or anxiety in pregnancy still had symptoms 21 years later. Are we really seeing relapse? Or are we seeing something different? And so I want to kind of propose a thought here. If the biggest risk factor for postpartum depression is depression or anxiety in pregnancy, and the biggest risk factor for pregnancy, depression or anxiety is pre-pregnancy, and the biggest risk factor for pre-pregnancy is childhood and adolescence, and then when we think about beyond menopause and beyond, for example, our greatest risk factor for depression or anxiety then is if we've had depression in postpartum, pregnancy, pre-pregnancy, or childhood and adolescence. I want to propose that instead of saying we're seeing relapse, we're seeing depression come back again, or relapse, I think we're seeing dysregulation of the brain and nervous system across women's lives. And pregnancy and postpartum are encapsulated in that, because they share every single one of these periods in time that we have identified as a silo, a period of time by hormones, really, is we have the same risk factors, the exact same risk factors. Now, the idea of dysregulation is not new, right? Why do we put babies skin to skin on the chest after they're born? We do that so that babies will regulate heart rate and breathing. And so what our nervous system is really designed to do, just to take a little step back, is react and quiet down again, right? If we see a car out of the corner of our eyes coming, or come out of the corner of our eyes, and it's coming really, really quickly, we should react. But then that car passes and doesn't hit us, and we want to respond by calming. So our nervous system is supposed to function like that. But a dysregulated nervous system looks like this. We react and we stay in high reactive mode, and we don't ever calm. And it's a little bit like a lighthouse. This is how I describe it to women, where we're just on high alert all the time. Danger, danger, danger. We're vigilant, hypervigilant all the time, looking for danger. That's dysregulation. So what dysregulates our nervous system? Anything that makes us feel unsafe or feels inescapable, like there's something terrible happening to me and I cannot escape it. I am doomed. The first thing we always think about is abuse, childhood abuse, partner abuse. But look at these things. Any of these things in our lives can dysregulate our nervous system. Accidents, surgery, early life stress that changes our epigenetics so that we are more reactive in our nervous system. arguments with our partner, grief and loss, feeling alone and unsupported, hurtful comments, not getting a promotion, feeling unheard, not being acknowledged. All of these things can lead to symptoms of depression, anxiety, stress, trauma, adjustment disorder. And if you look at these signs and symptoms of nervous system dysregulation, look at those. Those are our big four. So I want to try and meld this together for you a little bit. Whenever we think about dysregulation, the vagus nerve always takes center stage. It's the biggest cranial nerve in our body, runs all the way from our head down, innervates many of our abdominal organs. But I love this model by Deb Dana. She describes the nervous system as a ladder. And so she would say we need to be, and this is not she would say, but in her model, the ventral vagal place is the place we want to be, where we feel safe and connected and social. When something happens in our lives, let's say, let me give you an example of this. So you're driving through a Starbucks and to get your morning coffee, and you say, "Good morning, how are you? I'd love to have my latte, please." That's ventral vagal state. You're connecting, you're social, you feel safe. The world is a good and safe place. But now let's say that you get a text message from your partner, and that text message is a bit disturbing and jarring. That might drop you more to your sympathetic nervous system, where you feel danger, like you want to take action, fight or flight. You might send back a text that's a bit snippy. "I don't understand why you just said that to me." Something like that. But now let's say that your day goes on and you go to work and your partner has not texted you back. You might go down into a dorsal, where your dorsal vagus state is activated of your nervous system. And in that state, you feel like there's this life-threatening immobilization. You feel shut down and collapsed. It's the thing when you say, "I don't care. They haven't called me all day. I don't care anymore. I don't care anymore about this relationship. I'm getting out." Do you see the difference? We go up and down this ladder several times a day. But the key is to stay in this safe, connected, and social place. Because for the brain, the language of the brain and nervous system is safety. And so I'd like to propose that emotional well-being is not absence of depression or anxiety symptoms, but rather it's brain and nervous system regulation. It's knowing what our nervous system is doing, knowing how to move ourselves along that ladder back to a ventral vagal state. And so within that, I want to talk about what are our first line approaches. And I do think we're stuck like this sheep who cannot figure out how to get around that gate. In some ways, I believe that with perinatal mental health, we have not figured out how to kind of move beyond a medical model system. The current guidelines suggest we screen with a depression screener, anxiety screener. We follow it by a diagnostic evaluation. At-risk individuals with mild and moderate depression should be referred for cognitive behavior therapy, so talking therapy or interpersonal therapy, or an antidepressant should be offered. So our first line choices are depression or anxiety, are talking therapy, or antidepressants in the perinatal period. But let's just think about expanding those first line approaches, because I truly believe we have a broken approach because we don't understand what women want. And so what we're presently doing leads to fewer than 20% of women receiving needed mental health care. Look at that, 2016, and 10 years old, 10 years later, we have not shifted the needle. Half of pregnant women don't open up to their provider about their mental health concerns because they're concerned about being put on antidepressants. Are antidepressants bad? No, there's a place for them, but should they be first-line treatment as a routine, standard kind of approach? Clinically, our first-line approaches are really not based on the best evidence or guidelines. That kind of default based on availability. And often that default is medication because we have desperate women and desperate providers and few counseling resources, right? Few resources that are alternatives to that. But if you look at this study from 2022, that tells us that only 18 to 29% of pregnant women receive remission from antidepressants. So minimally, we need to make sure that we're creating reasonable expectations that only 1 in 3 at most of women really experience relief from an antidepressant. In summary, women experience inadequate responses to the current mental health treatment. So I do want to just push us a little bit to think about what could be a next direction. Our current system is really based on stabilizing symptoms for mom and baby while managing risk. But I think we need to be enveloping the evidence around neuroscience, which tells us about fetal programming and neuroplasticity, that the brain can change, and looks at brain-based interventions. And so I want to introduce bottom-up versus top-down approaches. This is not my original idea, by the way. Top-down approaches are those that rely on thinking, like counseling, like talking therapy. But bottom-up approaches are those that target the neurobiology or the brain and nervous system, and they're really focusing on changing the brain patterns, the brain physiology. Top-down approaches, example would be like cognitive behavior therapy, interpersonal therapy, acceptance and commitment therapy. You saw these names in the guidelines. And again, those are mostly talking therapy. They take a long time and they take energy. Bottom up, things like neurofeedback, biofeedback, eye movement desensitization and reprocessing, brain spotting, vibroacoustic stimulation. These are therapies that take very little time and change the brain. And so neurofeedback, the evidence shows it's as effective as any medication in the treatment of lots of psychological and developmental issues, often used to treat ADHD, trauma, concussion, migraine, depression, anxiety, as ASD, long COVID. EMDR, again, used for a variety of disorders. And some studies show, again, less time than a talking therapy, less dropout than a talking therapy. So listening therapies, these are based on vibroacoustic stimulation, which again is kind of vibrating that vagus nerve. And when the vagus nerve is stimulated, even through listening, because the vagus nerve crosses quite close to the ear, when we listen to certain frequencies of music, then that can vibrate the vagus nerve at a certain frequency, and that sends the signal to the brain that we are safe. And safe and sound is something that we can get certified in. Nurses, psychologists can get certified in that. Tomatis therapy is a form of that as well. So again, it's about vagal nerve stimulation. There's a couple things though that we can do and help if we're professionals, we can help our clients. If we're women just listening on the podcast, we can do these ourselves. So I call these the brain-based toolkit. Again, you can find this in your Brain on Pregnancy. We call it the B protocol. Our team does. It stands for breathing, ears, and eyes, and music at specific frequencies. But let's talk about breathing. You know, when we encourage ourselves or our clients to take nice deep breaths where we are literally, remember, are pushing our gut out and we feel that pressure against our spine. The reason that it's so calming is because it puts compression on the vagus nerve, which sends that signal to the brain that we're safe. So deep breathing is always a good place to start. And you can do it while nobody knows you're deep breathing. Ears and eyes. I want to just get you to do this, please. If you could just take your finger and put it in your ear above that little cartilage shelf. And then if you just rotate your finger clockwise, even 25 times, you don't have to do it 25 times here. And then you would switch and do the other ear, finger above the little cartilage shelf, moving that clockwise again. That again puts pressure on the vagus nerve, which sends the signal to the brain, we're safe. With eyes, this is another part of the B protocol. Just picture this. You're sitting in your office chair as you are. Look straight ahead. Don't move your head. That's your neutral position. Just move your eyes as far as you can in one direction. Let's say as far as you can to the left. You would hold that for 10, 15, 20 seconds. And then you would bring your eyes back to center. 15, 20 seconds in center, and then move your eyes all the way again, looking all the way to the other direction, to the right, for example. as far as you can and holding your eyes there for 15, 20, 25 seconds. That small technique, again, is very good at settling down the vagus nerve. So those are 3 things. You can even do them when you're driving the car. Don't do the eye one though, but you can do deep breathing or stimulate your vagus nerve in your ear. Steve Reese also is widely available on YouTube. He has done he was a nurse. He's done lots of research on the specific frequencies of HARP that allow us that stimulate the vagus nerve and calm us. And so those are really nice videos as well.
Just 2 minutes,
can you
Dr.
hear this?
Kingston.
Okay. Can you hear that music? Okay, well, we'll
No.
move. I want to end the presentation by talking about grief and loss because it's so often overlooked in perinatal mental health and in women's mental health in general. But this was just 1 year ago. And since then, I have lost my husband of 38 years, very unexpectedly, very suddenly. And as a result, really become very, very keen on grief and loss in our own work. And what I think I would say about grief and loss as I open up and talk about my own situation and talk to women and women open up, you realize that grief and loss doesn't stop for life, it just is layered on top of everything else that women experience. And so I believe that there's a special place for screening for grief and loss, for opening the conversation around grief and loss. And I want to share just a few resources. Alan Wolfelt is quite well known for his idea of companioning mourners. That is, we don't have to say special things or do anything special. We just simply need to be present. Mary Frances O'Connor has written 2 really nice books, The Grieving Brain, The Grieving Body. Robert Niemeyer from the Portland Institute of Loss I would say, his work really has focused on what is the meaning of our loss? What is the meaning of this loss in our lives? What does it mean to us? Again, Mary Frances O'Connor has some lovely TED Talks around what happens in our brain when we grieve. And just very quickly as we end, I want to share one small technique that I learned at a grief retreat, which helped me a great deal. And so this particular strategy is hands down on your lap. So you could do that right now. Place your hands on your lap. This would be the opportunity to share in all its rawness what you're feeling. And then after that expression, hands up on your lap. And this is the time to ask the question, and you can ask it just of yourself. What am I to learn from these feelings? What am I to learn from this yuck that I'm feeling right now? Or it can be a spiritual thing. God, what are you wanting me to take away from this? And so that's a very helpful strategy that has really carried me over the last number of months. And I just want to end with this notion that growth can arise out of the ashes of suffering. And in terms of resources, we have a website that has lots of free resources you can access. The Hope platform is also free, has lots of wonderful things. And then Your Brain on Pregnancy is another resource. So I do want to thank you for the opportunity to be here today and to speak with you about perinatal mental health and to hopefully challenge our thinking a little bit about how can we really help women who are suffering.
Thank you so much, Dr. Kingston. Thank you for sharing also your personal story with grief. And I know that Dr. Pollard is going to dig in a little bit on that side as well too. So we will get to the questions at the end here, but Dr. Pollard, will turn it over to you.
Thank you. I'll just share. Okay. Can you see my PowerPoint?
Not yet.
Oh. Okay. Uh,
Now, yes.
you can see it now? Okay. I just, okay. Are we good?
Yep.
Yes? Okay. So, thank you very much for inviting me here tonight. And Dr. Kingston, I so enjoyed your presentation. It's so insightful, and I learned a great deal from it. And I hope to carry on that theme of grief and loss in my presentation. First of all, I want to say thank you to Alberta Blue Cross and the Lois Hole Hospital Society for inviting me to spend time with all of you this evening. As I look back on my 40 years of nursing, I'm so grateful to have worked in antepartum and postpartum, and for many years, excuse me, in my career in labor and delivery at the Royal Alc Hospital. Throughout those years, I acquired skills and knowledge from some of the very best maternal health nurses I know. And 30 years plus later, I'm grateful for all our friendships that continue to this day. While there's so much I'd like to share with all of you, I understand I only have 25 minutes, so I'll get started. The topics that I'll be talking about today are on the screen. Excuse me. I'm just gonna have it. So before we begin, I'd like to briefly share a short narrative as how my expertise in obstetrics and my passion to serve mothers and their families during their loss has come to be. I'd like to introduce to you my father, Bob Greschek. At 65 years of age, my father celebrated 45 years with Park Memorial Funeral Home. He knew at a young age his purpose in life, and through a lifetime of hard work and passion for what he did, he became one of the most highly respected members of his profession. My father was the general manager of Park Memorial for 28 years, past president of the Canadian and Alberta Funeral Service Association, represented Alberta on the national board, and received an honorary life membership in Alberta Funeral Service Association. 3 generations of the Greschek family actually worked at Park Memorial over the many years. And in fact, I'm honored to be included on the employee list. During my summer vacations, my dad would employ me as a housekeeping person. And many times when my father thought I was working, I was truly observing him caring for people with such dignity and grace when they were at their most vulnerable. His honesty, integrity, and sincerity to meet their needs was really obvious to me. And after the family met with him, they seemed to be a little calmer, a little more at peace. While he had many accomplishments, I really think his biggest accomplishment was his humility and the way he treated everybody with such dignity and respect. As a labor and delivery nurse, I was honored to be on the perinatal loss team at the Royal Alc Hospital, especially because my father was on that committee. He represented Park Memorial Funeral Home, sharing his wisdom and donating baby caskets to our unit. After he retired, he enjoyed mentoring many who sought his wisdom. 2 weeks after my parents' 50th wedding anniversary, my father, at the age of 71, unexpectedly passed away a few hours after his open heart surgery. Our family was so deeply devastated. And at his funeral, through my immense grief, I promised him I would do my best to carry on his legacy. My father was the impetus for both my master's in perinatal loss and for my PhD studies in pre-death grief. While I really aspire to be like him, tonight I'll do my best to share my knowledge with you. So grief is a multi-layered, as Dr. Kingston said, life experience that is common to human beings as it's a natural response to loss. People suffer, agonize, and they struggle with a variety of multiple losses at various times throughout their life. Although we may all have experienced grief in a variety of ways, whether it be the loss of a loved one, a loss of a job, loss of health, the most significant point I'd like to make this evening is that an individual's response to grief is uniquely personal. So if you can remember this one important fact, that is foundational in how we support others in experiencing grief. Why is it important to talk about grief? Well, we know that grieving is very painful at times and a unique process, turning our lives upside down, inside out. And really, given the choice, it'd be easier to avoid this experience. However, in my grief education course, David Kessler shared, we cannot avoid grieving. We must go through the process to heal. And realistically, that's easier said than done. Nevertheless, healing is foundational to our mental health. So if you're going to go through this experience, why not let others express their love to you by allowing them to walk with you through this painful journey? Talking about your grief with others helps you heal and lets them support you. I have shared some examples of different types of grief, and it's important to note that a person may be experiencing grief in a way you might not have considered. For example, a delayed grief, a grief that we don't feel in the moment because it's not safe or we're in survival mode. A complicated grief when the painful emotions of loss don't improve with time and they're so severe that we have trouble resuming and creating our own lives again. Anticipatory grief, the grief that comes before death. So there's various types of grief. Professionals who augment the healing process of a person underpin their practice with various grief theories and models. Now, while it's been shown that grief theories and models are valuable in their utilization, some researchers have criticized certain theories and models, stating that various stages encloses a person's grief in a fairly rigid framework. For example, Dr. Kubler-Ross's theory of the 5 stages of grief. Therefore, it's important to remember while grief theories and models have been created from research, their purpose is to be used as a guide and framework to help identify appropriate support for grieving individuals. I'd like to briefly introduce you to some grief theories and models, so to augment your understanding of the various types of grief experiences, which can affect maternal health at any age. So all of us, I'm sure, know Dr. Kubler-Ross's 5 stages of grief. And David Kessler, you'll see in the picture there, he worked with Dr. Kubler-Ross, and he added a 6th stage of grief with permission from her family, and that is finding meaning. And we'll talk about that in a few minutes. The theory of ambiguous loss created by Dr. Pauline Boss in the early 1970s refers to a situation where a loss is unclear and not confirmed, leaving it unresolved. Now, there's 2 types. The first one is a physical loss, and that's a physical loss without clear proof of death. And a type 2 is a psychological loss, and this occurs when a family member is physically present but psychologically missing. Dr. Therese Rando, she explained that a person experiencing anticipatory grief is aware of the dying person's terminal illness. She's well known for her 6 R's and her process of mourning model. Dr. Doka introduced disenfranchised grief in 1989, so seems pretty recent, describing it as grief that is not recognized or supported by society. Disenfranchised grief can happen in many situations, such as losing a pet, going through a divorce, having a miscarriage, losing a job. So even though these individuals really feel a deep sorrow for their loss, social norms may stop them from having rituals to show their sadness or to get support from others. And Dr. Margaret Strobe and Dr. Hank Schultz created the dual process model of coping with bereavement. And this is a model that I really like and actually really look to in my PhD studies. This model talks about 2 coping mechanisms. The first one is loss orientation, and it's focused on adjusting to the loss. And the other one is restoration orientation, and it's focused on how to move on in the light of the loss. So basically, these 2 researchers believe that a person will move between the 2 types of orientation, and they think that this is both necessary for adaptive grief work and adjusting to life without their loved one. Grief is what is going on inside of us, while mourning is what we do on the outside. And sometimes these two terms are interchangeable by people, but truly the internal work of grief is a process, a journey. It doesn't have prescribed dimension, it does not end on a certain date. And when people are mourning, you can't judge their grief based on who is crying the most. While we know there's no timeline in grief, and no two people will experience grief in the same way, the timeline I'm showing you right now may be helpful to gauge certain interventions. So, anticipatory grief is a grief before death. Acute grief is when it just happened. Early grief in the first 2 years, and mature grief is the rest of their lives. Perinatal loss, a mother's unforeseen loss prior to pregnancy, during pregnancy, and after birth. And death will shape our grief. Two people can have the same death event, but each person will experience it differently because grief is unique. Therefore, we should never ever assume we know how a person feels, even if they have experienced the same death event. Now, on this slide, you'll see the types of perinatal loss prior to pregnancy, during pregnancy, and after birth. And working at the Royal Alec Hospital, it was such a privilege to work there. We specialize, of course, in all types of deliveries, but we get the deliveries that may be a perinatal loss, etc. And Patty Walker and her team and the labor and delivery unit and postpartum, antepartum, all those units and nurses are incredible in how they take care of the mom and the family. And it's really focused on the mom and the family, the holistic care. As I said previously, a person uniquely experiences grief. And so grieving style is formed by a person's personality, gender, and care and culture. All these virtues must be respected for a person to express their grief in their own way. Parental grief has been recognized as the most intense and overwhelming type of grief at any age. My grandmother, 91, deeply grieved my father when he died at 71 years of age. Even though a mother and father experience the same loss, their grief reactions will be unique. And I think this is so important to remember. Therefore, depending on their personality, their support network, previous loss experiences, life experiences, the attachment to the baby or the pregnancy, the events of the loss, everything will really change their experience and be imprinted on their experience in terms of length and depth. Very often, of course, a woman is the focal person in a perinatal loss for many reasons. And in addition to the heartbreak of losing the unborn child, the mother's body will still be changing in a postpartum state. She'll still continue to have pregnancy hormones, produce milk, continue to have changes in her body as it readjusts after the loss. So grief may be focused on the loss of the child, as well as the loss of the mother or father's hope of being a parent and their new role. There's an assumption that the partner bonds less deeply than the mother with the unborn child, and in doing so can be less affected by the loss. However, in my experience, many partners experience a deep and intense grief and often put these feelings on hold because they want to support the mother and they want to carry out everyday responsibilities. Therefore, it's important to assess the biopsychosocial and spiritual needs of the partner as well. Furthermore, a perinatal loss can create strain on a couple's relationship, and including sexual difficulties after the loss. If a couple does not understand each other's way in which they grieve and cope, or have the energy to support each other, this could further put strain on their relationship. Again, depending on the couple and the relationship, the experience of loss may also strengthen the relationship. Lastly, it's important to note that their grief will continue to ebb and flow, and the intensity may be triggered on special days like Mother's Day or Father's Day, the baby's due date, and perinatal grief can be profound, not only for the parents, but for the whole family. It's important to remember that this is your grief. If you are the one dealing with a loss, it's your grief. You don't need anyone's permission. You need to be patient with yourself. You need to grieve fully and live fully. Ask for help. Everyone's so willing to help. Professionals are willing to help. Your social network are willing to help, and take baby steps. What I think is really important, and what I found out when I was doing my master's regarding perinatal loss, is the worst and best things you can say to somebody in grief. So the worst thing is everything happens for a reason. God needed an angel. At least you didn't know the baby. Be grateful for the children you have. You need to move on. I mean, those are heartbreaking words to hear and can really impact a woman and spiral her down to a point where, she may be on antidepressants, needing therapy, etc., maybe develop a chronic illness or whatever. But those words are so impactful and so hurtful and so detrimental. Here's some better things you could say. I'm so sorry for your loss. What's the hardest part for you right now? I'm here. I'm ready to listen to you. How can I help you? What do you need right now? Take all the time you need. David Kessler shared that there are 6 needs of grieving and that a person will experience them. And these are the 6 needs of grieving of everyone in general. He also said, if the love is real, the grief is real. And I certainly believe that. The first one is to have your pain witnessed. It's really important to have a way to witness someone's grief. You want to be with them. You want to hear them, see them, value them when they are telling you about their grief, and help them find a way out and help them find what they need. Always accept the person where they are at the moment, and this will help them move along. To express your feelings. We get very afraid of our feelings. Therefore, we must find them because we can't heal what we can't feel. And David Kessler said that over and over again. Our work is to help people feel safe so that they can express their feelings. To release the burden of guilt. One of the needs of the grieving is to be free of guilt, but guilt isn't something we let go of easily. People tend to hold on to their guilt and only gradually make room for a different, more freeing story. To be free of old wounds. Emotional wounds can deeply impact and shape our lives in many ways and are more likely to come up during challenging situations like grief. We are looking back at old wounds not to reopen them, but to heal them so that they don't create additional pain in the present. To integrate the pain and the love. Our grief isn't a final emotion because we continue the connection as we bring our loved ones along in the future. The word future is important because there's no going back to who you are before the loss, because we've changed, we've experienced a loss, and we are experiencing grief because of that loss. But remember that you're still a whole person. In our lives, we integrate grief and loss because we are a whole person living a whole life. A whole life includes pain and joy as well. To find meaning in life after loss, I will address that soon. Being present with someone is so important and is crucial to their healing. And Dr. Kingston mentioned Dr. Wolfelt, and I was fortunate to meet him. And I'm going to talk a little bit about companioning that she alluded to. Companioning, Dr. Wolfelt states that companioning the bereaved is not about assessing, analyzing, fixing, resolving another's grief. Instead, it's about being totally present to the mourner, even being a temporary guardian of their soul. I think that's so beautiful. The companion model is anchored in the teach me perspective. It's about learning and observing. As a companion to the mourner, you really need to create a safe space with a compassionate heart so that a person can embrace the feelings of their profound loss. An open heart will allow you to be truly present with another human being who's sharing their deep and profound loss. How do I grieve, or how do I walk beside a person who's grieving? Truly, David Kessler, he said, you can't fix anyone's grief. It's an internal journey, but you can sit with them, be present with them, listen to them, and actively listen to them. Look at them when you're listening to them. Look in their eyes. Look down to their soul. Really engage with them. They need to be witnessed like everyone else. Let them know that the pain will change and will change in its own time, in its own way. Affirm the enormity of what they're going through. And check your own discomfort. You need to be really well prepared to be with them on their journey. If you're not prepared and you're uncomfortable, you're not going to help them. You're going to be a barrier to their healing. Acknowledge that grief needs dedicated time, and acknowledge them that they're taking the time for grief. Ways to hold hope for people you're working with or walking with. Notice the changes that they have and the ways that they're still living. Tell them that you understand it feels hopeless, because that is the truth. If they're feeling hopeless, tell them you understand that. And share with them a gentle reminder that people all around the world have been through horrific things. And they'll probably say to you, I don't care. But you can just remind them that they still found hope later. It doesn't mean that they didn't have a period when they didn't see it. David Kessler's Finding Meaning After Loss include these points. Finding gratitude for the time you had with a loved one. Really appreciate that time you had, and find a way to commemorate and honor them in any way you can. Feeling changed by knowing that they were in your life. Feeling changed by their death. How did their death impact you? What did you learn from it that really benefited you now that they've passed on? Creating something of meaning for others. So maybe that something that, like their death, impacted you in a way that now you're doing something for others. I know that when I had a mother and her husband and her mother-in-law come in, and we had a stillbirth. It was a long weekend. There was no one in case room in terms of a chaplain, social work, or anything like any other healthcare professionals like that. And so I was stunned. I thought, what do I do? What do I do to help this couple? And then I thought of my dad, and I called my dad and I asked, and I didn't break any confidence, of course, talking about them, but I asked if he might be available to see this family. And he said, yes, tomorrow at 10 o'clock, he would love to. And so I went and spoke with the family, and they thought that they may, and so then the next day, I remember I was working evening shift again on the long weekend, and they came up. And usually when people come back to case room or labor delivery, they forget things, of course, because there's so many things to take down to postpartum. And I asked them, I said, how they were doing, and did they forget anything? Do I need to go back to their room or whatever? And they said they just came to say thank you. Because they enjoyed the conversation they had with my dad, and that it really put them at peace. And I thought, oh, wow, that's awesome. Like it was just so wonderful that that we could help somebody through what they were going through. And that was really the impetus for my study and my master's, because I thought if I could help one family, maybe I could help another. And then hopefully by teaching and sharing these stories with my colleagues and my students, they too can do the same. So also the last point that David Kessler makes is realizing the shortness in life and the value of life and making that a springboard into some kind of shift or change. Interventions are very important because the healing of grief begins when we allow our hearts to be open and vulnerable. And that's very difficult to do, but we need to do it. We need to go through the process. We can't avoid it. I mean, we can only avoid it for a certain time, but it's something we need to go through in order to heal and come back to a mental state, hopefully of peace and calmness. So it's important that we really open up and try some interventions that might work. And here are some suggestions. Acknowledge your feelings, which I spoke to before. Seek support in terms of friends, family, professional counseling. Likewise, can be very rich in helping you heal. Journaling in a sacred space or using a special book to write your feelings down. No one will see them. You get them out. Create a memory ritual, which would be like maybe going to a baseball game on the birthday of the son that you lost because he loved baseball. Practice self-care, so important. Eat right, sleep well, make sure that you're out getting exercise, etc. Mindfulness and meditation, which Dr. Kingston spoke about, the vagus nerve and how important that is, the breathing techniques. Allow time for healing. Grief yoga focuses on mind, body, and spirit, and it's very good for many people. Set small goals, not big goals, because then you get frustrated and feel like a failure, and educate yourself on grief and things that will really empower you. Working as a labor and delivery nurse, I was honored to care for mothers and their families during perinatal loss. And I always asked, and when we knew STARS was coming in or an ambulance, I always asked if I could, take that patient and her family. From a biopsychosocial and spiritual perspective, when we talk about those needs, the biological care parallels another mother's postpartum care, of course. However, the psychological, social, and spiritual care that we give to these moms takes a new trajectory. It's critical that the healthcare professionals caring for the mom and family provide the appropriate care to meet their needs. Most importantly, their care needs to be supported by the healthcare professional with an attitude, knowledge, and perspective that will not be a barrier to the healing, but will appropriately augment the healing of the mom. I developed a reflective questionnaire tool to assess the attitudes, knowledge, and perspectives of the interprofessional team members, which will work with the mom. That includes nurses, physicians, social workers, and chaplains related to perinatal loss. And the tool was also designed to determine comfort levels in dealing with perinatal loss, which is so important and crucial. And indirectly, the tool taps into the spiritual values and beliefs as well. This poster presentation, I was fortunate enough to present in Bern, Switzerland. Likewise, I developed modules for the Royal Alk Hospital Labor and Delivery, as well as for other interprofessional healthcare team members to provide pre-death and bereavement education and skills to benefit them in two areas: in the development of their personal insightfulness and professional competency, so that they could provide effective holistic care to the mom and her family who have experienced a perinatal loss. And I'm just waiting to hear about possible funding for the program. I'm very happy to see this assessment published in 2020. It just shows me that the focus on the biopsychosocial and spiritual needs of the mother and her family are at the center of care. I'll provide a self-care assessment and a stress workbook that may be helpful to you, and I will give this to the Lois Hole Hospital Women's Society, and from there you can access it. They're free. Okay, I really like this slide. How is your soul? So when someone who really knows you and cares about you asks, "Are you okay?" Their concern for you and willingness to be there to talk can really soothe your soul. And truly, that's the essence of who you are. In closing, I'd like to say that grief is for the living. Therefore, through integration, we are recognizing the pain that we have and recognizing that we're continuing to live on. It's like taking a new colored thread. Instead of trying to mend the hole in our heart or the hole in our tapestry of life, we're threading a new color, a new way of living amongst all the old threads in our beautiful life. Thank you again to the Alberta Blue Cross and the Lois Hole Hospital Women's Society for inviting me to spend time with you this evening. And a very special thank you to all of you for your time that you spent with me. Thank you.
Thank you so much, Dr. Pollard. And I think we have a few questions that have come in, and a couple shout outs to you from your nursing days, it looks like, in the chat. So that's lots of fun. Um, and I wanted to start with a question about for Dr. Kingston, which was about the ROSE program. If that was something you were familiar with. The asker writes that it's a proactive approach to perinatal mental health. And if you've heard of it, do you mind sharing any thoughts you have on it?
Sorry, Brianna, was that the ROSE,
Yeah,
ROSE?
ROSE program.
You know, I haven't heard about it. Yeah.
Me neither.
So,
But
but
it's
I'll look it up with interest, that's for sure.
yeah. It sounds like this individual's involved with Central Alberta Maternal Mental Health Steering Committee and are looking for ways to support the population better. And their peer support is an area of focus at this time. And they were wondering if you had any thoughts about what you found in regards to efficacy of peer support models.
So, I mean, there's all kinds of evidence, probably 15 years of evidence showing good effective peer support. I think a lot of it's been done in Toronto. Cindy Lee Dennis has really led out that work. And as far as I can tell from reviews and whatnot have been done, peer support is a very effective model. With training, maybe I should say that, with the caveat of good training, good support, ongoing, I think peer support can be very effective. That's what the evidence shows.
And maybe for both of you, can you give examples of what that might look like in your populations?
Yeah, I can start out, Lori.
Sure.
I think I'm just trying to think about in Toronto, the studies that were done. I think that they were done in affiliation with public health. And so it was women that had experienced a perinatal loss or premature birth or depression or anxiety, postpartum depression. And women who had the experience, so they weren't professionals. That's what a peer is, right? It's not a nurse, not a counselor. They are someone who has had this lived experience. And so they come alongside the woman who is suffering with depression or anxiety, postpartum depression. And I think they just meet with them. And I think that takes several or various forms. But I think the idea is to both comfort, normalize what they're walking through, and help them to connect to resources as well. That's kind of what I understand the peer role is. And I can see, I mean, I think it takes some organization at the top end. These are unpaid positions, it's volunteer, but I think it could be very effective. I'm inspired to know something like that is happening in Alberta. Yeah.
And Dr. Pollard, do you have any thoughts on peer support when it comes to grief?
Yes, it's interesting because David Kessler has, it's called Tender Hearts. It's a group of peer support, and you support each other. Like Dr. Kingston said, when you've gone through the same death event. And so they claim that, and research has shown that the understanding or the empathy that is shared between the two, because you've shared a same death event, is really therapeutic. Also, grief is really unique. So we have to remember that as well, right? Although we may have had the same death event,
Mhm.
we need to have probably that mindset of companioning, with each other where we're sharing what we have. But sometimes that gives solace to the person in their grief.
Right. It can be an isolating experience.
Mm-hmm.
Dr. Kingston, can you share a little bit about the HOPE platform? There's a question specifically about is the HOPE platform allowed to be shared with organizations that provide perinatal mental health care? And I think because it's such a fantastic platform, maybe you can just speak about it for a moment or two.
Yeah, happy to. So this were, and I love this, the Hope platform because it was really developed over the last number of years in partnership with Royal Alex Hospital Foundation and with so I absolutely love it for that reason. The Hope platform started as a resource for perinatal mental health challenges, has screening tools, education, online therapy, lots of resources. And then in the last couple of years, we expanded it across lots of women's mental health challenges or across the life course. And so we have some stuff on grief and loss, menopause, trauma, life experiences, stress, etc. So it's a free program, can absolutely be shared. If you want to share easily, we have QR code to it as well. So we can absolutely provide any resources that might help that. But yeah, it's available to organizations, and we're incredibly grateful for Royal Alex, for the Lois Hole Hospital for really supporting this work in such a significant way.
Mm-hmm.
We'll be sure to provide links to that as well. Thank you.
Yes.
Do you, there's a question here about nutritional components to mental health and depression. Specifically, do you feel there's a nutritional component involved?
Yeah, and I'm not an expert in that area, which is why I really don't tip my toe into it. But I mean, the guidelines, the sort of national guidelines do talk a little bit about some supplements that are really helpful. We work really closely with a neuroscience team in the US in Texas, and the Houston Brain Institute, and they are very careful to assess women's diets as part of depression and anxiety. And I think their own work clinically in research would support that there's a pretty important nutritional component. And I can certainly, if the person would like to contact me, reach out, I'm happy to sort of dig up some good evidence-based resources around that. But I'm not an expert in nutrition, so I've tended to kind of not speak on that. But is there a role for it? Absolutely. Um, Brianna, can I also say, I'm not sure, I know Chelsea mentioned about
Mhm,
in the chat. I'm not
mhm.
sure how to connect with Chelsea, but Chelsea, if you're still listening, please do reach out and we can connect
Yeah,
after as well.
Chelsea, if you are able to send a message to just the host and panelists with your contact information, or you can reply to the email that you received with the webinar invite, and then our foundation team can put the two of you in touch. I'm sure that would be all right. So it
Yeah.
sounds like some collaboration would be fantastic.
Yeah. Thank you very much.
A question here about postpartum anger, or sometimes referred to as postpartum rage, because I know we touched on postpartum anxiety and depression. And can you speak to strategies for postpartum anger or rage?
Yeah. Have you ever, the person that posed the question, have you ever seen or heard about that kind of idea about the iceberg of anger? It's a really useful picture, so you can find it anywhere on the internet. It's a really popular, but anyway, the idea is the anger is the tip of an iceberg, and underneath the iceberg, under the water, is everything else that's kind of driving the anger. And so the thinking behind that is anger is not, it's not its own disorder. It's more of an outworking, a volcanic outworking of lots of other stuff that's going on underneath. And it could be anything from not being acknowledged, from childhood trauma, from abuse to, you know, frustration, can be any. So in treating anger or in thinking about it, it really is about what's driving the anger and looking under. And so that can be useful even to look up that on Google
Mhm.
and to just find out that, what are some of the things that drive anger? Do any of them resonate with me as I read resentment, grief and loss, right? What are the things that are driving it? So, and journaling can be very helpful for that. And even in my grief journey, I
Mhm.
journal as a way of tapping into my feelings and putting words to those things that I'm experiencing. So that can, I think, could be very helpful in the rage part too.
And I think there's often an anger component, like even when you were talking through the traditional stages of grief, Dr. Pollard, and so that can sometimes be involved at that phase of life as well, or experience of life.
Absolutely. And I think it's important for people to know that it's a natural response
Hmm.
and it's something not to beat yourself up about. Excuse me. It's something that you may need to go through,
Hmm.
in order to heal. And that's okay. It's okay.
And journaling is a tool, and lots of tools to kind of try to get underneath of the tip of the iceberg to try and sort out what's at the root of it, so to speak.
And sometimes when you just talk to someone and they just listen, you can
Hmm.
almost give your own therapy to yourself because you're just talking everything out. And then all of a sudden you hear what you're saying and you think, oh, okay, now I get it. Thanks. And they're like, I didn't do anything, but that's why listening is so important, and to actively listen, to really listen with a connection, with empathy, with that like being really authentic with, can just help a person tremendously, another person. Mhm.
And
I wonder,
that, no, go
I
ahead.
wonder, oh, I was just going to say, I wonder if I could pop into a very real life example. Can I do that, Brianna?
Yes, please. Yes.
On our farm, I generally do rounds late at night and I come around and I come through the ram pen, and we have 17 rams and they're just lovely. And I stopped there and I just had such a heavy heart and I was angry and I just had, this mess of emotions. And I just let her rip. I totally let her rip. And I cried and I just yelled and I prayed my neighbors were not outside, let her rip, turned around to find my circle of rams in a semicircle around me, all looking up at me. And I thought, well, that's a listening audience. So anyway, and
And it helped, right?
it helped.
There you
Yeah,
go.
it absolutely helped.
Yeah,
Yeah.
it's so wild how many of our emotions like we don't get to express. And I mean, hearing that from you after your presentation and your demeanor and your calm persona, it's like, yeah, like we all have those moments where you gotta let her rip.
Yeah, yeah.
You can't keep any, well, you can't, if you keep it inside, it's just going to get worse, right? And
Mhm.
it'll just eat away at you. And and maybe even become that barrier to your healing.
Mhm. And I know, Dr. Pollard, you shared that you have a workbook for that folks can access and work through. And
Yeah.
and I'm curious if you think that could be helpful for folks supporting someone who's grieving, whether they're not necessarily a direct family member, but a friend or a family member, like if those looking at that workbook that's designed, I think you said it was for grieving folks.
Stress.
Yeah, oh,
That
stress.
was for
Okay,
stress.
pardon me. Okay.
I think it'd be very helpful because, and Alberta Health Services actually puts it out. And I
Amazing.
think it would be very helpful because it's a beautiful guide, and so when you're with somebody,
Mhm.
helping them through their journey, you can get a lot of good ideas, and you can do it together, and yeah, it's really good.
There's a question that came in about prenatal education and prevention around anxiety and fear. So the specific question says, could you speak to the role of better prenatal education needed so mothers to be have less anxiety and fear of the unknown?
Yeah, do you mean sorry for grief or sorry,
It,
Brianna?
I mean, it's specific to anxiety, but I think it applies in both. I think there's a lot of, even when we look at perinatal loss, there's a lot of lack of information. We don't talk publicly about it, stigma, all of that. So I think maybe we can maybe both of you can chime in.
Sure. Some of the early work that we did around understanding why women would or would not divulge how they're doing really showed us that there isn't often an opportunity, that there isn't a sense that other people are suffering. And so I think one of the first things that
Mhm.
education would do is could really identify, you know what, 1 in 4 women, look around this room, there are 4 of you sitting there, one of you probably is struggling. That's kind of, women want to know that. They want it to be normalized because they feel so unusual when they struggle with anxiety or depression and the expectations of stigma. We know all that. But the experience of that for women is very blocking. It means that they carry lots of shame and whatnot. So is there a role for education? I would say the very first place is let's normalize what we're seeing.
Mhm.
Let's understand how common this is. Let's understand, and I love the model of dysregulation because you know what it says? Somewhere along the line, my nervous system and brain have been bumped and jarred.
Yeah.
And
Right.
therefore, I'm responding in this way. So, do I have to go back and sort all that out? Not necessarily. Are there strategies that can help? Absolutely. But if we saw it as dysregulation where life in its difficulty has jarred us, that is far more accepting than I am this flawed, broken person. My grandmother had depression. I'm certain that I have no hope,
Mhm.
where that looks like. So I
Yeah,
think normalizing that this is really a critical starting point.
I agree with you, and I think just normalizing empowers people because then they think I'm okay, first of all, right? My one of my goals is I would love to create a program where moms, when they go to prenatal education, I used to teach prenatal classes, and when you care for a mom who's in labor and she has had a loss previous to the pregnancy she's in labor with, those moms are so different, so different. And both moms have to know that it's a different process, and the nurses have to know, and the physicians, because our purpose is to really have a safe delivery for mom and baby. But if the mom is so stressed, and every time we have a decel or something happens, um, the moms get overworked, that really impacts their labor. It impacts the baby. It impacts their own cortisol levels. It impacts so much, on so many levels. And I think if nurses, physicians had more education in that area, and likewise the moms, I think the moms would have maybe a better experience, because So many of their past experiences and their feelings come up when they're going through what they're going through. So I really think education, we know that our knowledge empowers people, but I think we really have to get specific with that, because there are a number of women who've lost, previous pregnancies, right? And babies, and really need that support. It's so different, and they really need it.
And that's such an interesting, like, I'm so interested in that, as far as like, how do those deliveries, what outcomes do we have as far as like the actual delivery, the birth, like do we see more cesarean births, or do we see more intervention, or less, or like what are that I'm sure that data exists. I'm not aware of it, but I think, and then having standards of care around that, when you're able to have someone disclose that they've had these previous experiences, like that's fascinating to me. I had never thought of that in that way.
Well, because a mom could be always on the call bell and
Yeah.
always nervous and always asking. And someone who doesn't, maybe a nurse who's just starting out, in her profession, in case room, and she doesn't understand that, or she's never experienced that. And she might get frustrated with this, thinking, come on, I've answered all your questions. I'm doing everything I can. What more can I do? And that energy that she gives to that family, they feel it,
Right.
and then they feel like, oh, I'm not going to disclose anything. So like Dr. Kingston was talking about, they kind of hold back, right? Because now they're going to be stigmatized, or, they're the patient that's always complaining, right? But
Yeah.
it's not that. It's just such fear of the unknown, what will happen.
Yeah,
Yeah.
absolutely. And I know we're at time, but I selfishly have a question. So I had my baby in 2021 and participated in the pregnancy and the pandemic study with the University of Calgary. I still get emails and I still fill out my little questionnaire, so I'm trying to be a good study participant. But I'm wondering if we have enough information yet to know if women who had pregnancies or births during the pandemic had any changes in their postpartum depression risk. I know personally I struggled immensely with postpartum depression and anxiety and was not diagnosed, even given all the knowledge I have in working in healthcare. And so I think I want to share that because, again, breaking the stigma and talking about it is so important. But also I have this personal curiosity about postpartum outcomes in that short window of time.
No, thanks for sharing
Yeah.
that, Brianna. And I think it's just, again, part of normalizing the experience during COVID. Anything I've read, and I haven't delved deeply into it, but shows that, the rates of postpartum depression, anxiety, et cetera, were much higher during COVID. But what I've found interesting is that actually they stayed quite elevated.
Right,
And I don't think we've got a full, explanation for that.
right.
Um, have you read that too, Brianna?
Yeah, I would say I see that also in clinical practice, where there seems to be a higher, and is it an issue also of like incidents where we're seeing it more because we're diagnosing it more because we're assessing people more? Like, I think that those are things that we have to look at and tease out over the next few years.
Or it's interesting, again, thinking about that kind of dysregulation. If it's dysregulation and these really disturbing things happen during COVID, everything from, laboring without support and not being able to have family support, and really walking this journey very, very, in a very lonely way in lots of ways. Was that jarring enough to the nervous system that's what we're seeing? We're just seeing that
Right.
carry on forward. And so, do we need to start thinking about sort of those interventions that can settle our nervous system back down from this traumatic event that we experienced?
Yeah.
And I think too, society, often we're in such a fast society, right? And it would be like sometimes people wear the honor, the more they do, the better, blah, blah, blah. We've
Right.
all heard that. And so I think likewise to give that education that it's normal, you're okay. And as soon as you hear somebody say that initially, then I think they settle down, they take a few deep breaths, that vagus nerve, but also then they're willing to say, okay, what do you have to say? Because if you think I'm okay, then let's keep going. Like, meet the person where they are and move forward, instead of making them feel berated, right? Because that doesn't do anything. But yeah, I think through education, through patience, just to know that you're okay and we're going to help you, and that will take a lot of I think pressure away, or kind of weight off their shoulders.
Yeah. So accessing supports, and also for those of us that support, being the support for those folks who are struggling, right?
Yeah.
And I just want to thank you both so much. And thank you for digging into my selfish little conversation there for a moment. I appreciate it. And I love that our online community stays so like vibrant and engaged with these conversations between us. And if folks that are still on the call would like to continue supporting the Women's Society, we'd be thrilled for you to consider joining as a monthly donor. And Ijoma's going to share a slide real quick. And this recording will be also available on YouTube shortly. Ijoma, I'm going to turn it over to you to close. And again, one last thank you so much to Dr. Kingston and Dr. Pollard.
Thank you. Thank you. It was my pleasure. Thank you.
I want to echo those sentiments and say thank you to both of you again. That was fantastic. We appreciate you and hope to have you back again someday. I also want to extend a very special thanks to those of you who support monthly and continue to be active supporters of the Lois Hole Hospital for Women. Just being here tonight makes you one of those people, so thank you so much. Thank you to our presenting sponsor, Alberta Blue Cross, and please keep an eye out for a feedback survey that's coming your way. Complete it to enter a draw for a $25 gift card courtesy of Alberta Blue Cross. The winner will be contacted directly. Thank you for joining us, and we look forward to seeing you all very, very soon at our in-person Between Us event on June 12th. Have a good evening, everyone.
Thank you.